Today's discussion is on Stephen King's Misery. Again, this is commemorating especially the professional career of James Caan, who unfortunately passed away, and his depiction of the character of Paul Sheldon. But we could start anywhere the group chooses. Is there any particular character in Stephen King's Misery you would like to start with? The answer cannot be a consensus, no. You're going to have to choose a character.
The main character.
All right, so we'll start with Annie.
Yes.
All right, so what caught your eye?
She seemed highly reactive, and I don't know if this is the right term, but like labile in terms of she would be like really okay one moment and then just snap on a dime and go to like insane happiness or insane is not the word, but like high happiness, high anger.
Intense.
Yes.
Yeah. So the change pattern was noteworthy, right? You had mentioned that it would be your clinical description, your opinion that she's mood labile, right? It's a little bit of a misnomer. The affect is labile, specifically the affect's change pattern.
Okay.
Right? Now, just like any physical exam finding, that doesn't tell us anything in terms of diagnosis. But surely as we kind of go forward with this conversation and come up and develop a differential, your finding, that clinical exam finding, could certainly support that diagnosis. Or maybe not, maybe direct opposite, right? To be seen. Any other observations?
She, in addition to the like mood labileness,
lability, you're right.
You do see her being pretty depressed when it's raining outside. And she says she gets like that whenever it rains, so there's definitely a recurrent nature to depressing her.
You know, it was interesting to me that I got mixed signals there, and I think as a psychiatrist, I would follow up with a question. She mentions the rain sometimes it gets me down, which would be consistent with perhaps what subtype of major depressive disorder? Right? So I think that should pop up in her head, but then she actually describes why she feels depressed, and it has nothing to do with the season, right? Do you remember what she says?
Doesn't it have to do with her husband or no?
Well, I think it does have to do with her husband, but what she tells us on the surface, no. Who does it have to do with?
I can't
remember. Who's her displaced husband in this movie?
Paul Sheldon.
Yeah. And so yes, from an analytic perspective, it absolutely has to do with her husband, perhaps even her dad. But we're not going to go that deep yet. She mentions that she was always in love with the writer, Paul Sheldon, but now she realizes that she's in love with the whole person. Okay, paraphrasing. Which has nothing to do with the season. So, and clearly something to do with why she's so dysphoric. So why is she dysphoric, and why should have Paul at that point should he have grown to be very concerned?
It's almost like a delusional disorder, especially, I guess you could say erotomania as the subtype. She's obsessed with him, and it's reading into kind of like manifesting that he's also growing obsessed with her.
So you use some very big words there. So let's start out with the idea of a delusional disorder. What is that?
Fixed belief, like non-changing, even when provided evidence to the contrary.
Yep. So that's a delusion. And how as clinicians do we kind of gravitate from what you just said, establishing the delusion to this condition called delusional disorder?
Length of time.
Yeah. So the individual has an established delusion that actually results in clinically significant distress or impairment. Right. Hence, we now can use the D word, the second D word, disorder. There are 5 subtypes. Who's brave enough? I already heard 1.
Persecutory.
2.
Grandiose.
3.
Aromatic.
Right, that's the.
It
is. That's the correct way. It was not aromatic. Right?
I knew it was with an E. I was trying hard.
That's fair. We're still stuck on 3 though. That counts as number 3. Still 2 more.
Delusions of grandeur.
We did that
Somebody
one.
said that's
I forget what it's called, but there's one where it's like they think everything is that delusions of grandeur, but it's with God, like everything's like religious or not.
Same. That's the same.
one.
Yeah. In terms of this oversimplistic classification system, it's the same.
Is there like a somatic subtype?
4. Anybody here Seinfeld fans?
I've seen a lot of Seinfeld.
So,
Yeah.
how about Elaine's ex-boyfriend, Joe Davola? I think, if I recall correctly, pulling this out of left field, the opera.
Does he cry at the opera?
Huh?
Does he cry at the opera? I forget what happens.
I think he does cry at the opera, but he begins to have the delusional belief that Elaine is still in love with Jerry and not him. Questioning her.
I would say
Jealous type.
Oh.
Yeah. So the acronym is JPEGs, right? So jealous, persecutory, erotomanic, grandiose, somatic.
I like that. I like that.
I haven't
Yeah.
seen that before.
So how I'm going to be a little tricky today. So who had said erotomania or erotomatic subtype first? Okay. If you're going to put this on the medical record, do you agree or disagree? Anybody here agree with the diagnosis? And let's say that delusional disorder is in fact correct. So we're focused on this diagnosis, and I'm going to reassure you at this point that it is correct. Erotomatic subtype. Agree or disagree?
I guess I have a question, and that is typically when in that case, isn't it like they think that the celebrity is obsessed with them? But what if it's the other way around in this case, where she's obsessed with the celebrity? Could that? I guess it's like a follow-up question, but
Yeah, so I don't know if we have a neat subtype to explain
Yeah.
that. However, I will say that it is my medical opinion that Annie Wilkes is in fact of the belief that Paul Sheldon is in love with her. All right.
I was thinking about that when I was watching it. I think maybe to an extent, but maybe there's like certain points where she has like clarity, because she says stuff like, oh, like there's that scene where she's really upset, and when she's upset from the rain, she says like, or he says something like, oh, like I love you too, something like that. She's like, no, you don't. Like it's nice that you said that, but you don't. And she has those moments of like realizing that he's lying to her.
Yeah, she does. She has those moments of insight, which is why Paul is all of a sudden and instantly in imminent danger, right? Because her delusional system is falling apart. Right? That's the whole movie. But let's establish the diagnosis first. Who here agrees that the best subtype fitting Annie Wilkes is erotomatic subtype? Anybody disagree?
I guess you can also maybe throw grandeur in there.
How?
She seems to almost, I guess, jump into another personality disorder, like be narcissistic in ways, and have like a heightened sense of her own purpose. And you see from her memory lane photo book that she's like killing people left and right. Oh wait, no, I guess that's jealousy.
That could be jealousy.
Yeah.
But there is evidence of grandiosity, though, isn't there?
Because she thinks that God talks to her.
Yeah.
So that's, yeah.
So if we think that the scenes that we just identified are in fact linked to her false beliefs, her delusions, and we identify that in addition to erotomania, there appear to be jealous and grandiose episodes as well, what is the single best answer? Mixed type. Right? That was my trick question. That's exactly what I was getting at. So good pickup, and recovery. I almost had you on the hook for getting one wrong. You escaped in the nick of time. Mixed subtype. And I do believe that she is mixed. She does speak to God. She believes she has spoken to God. I don't think she's being dramatic there. And then we look at memory lane. There's intense jealousy lending to. I don't think anybody would have any problem with clinically significant behavior. right? Murder. All right, so maybe delusional disorder and maybe high in our differential at this point. Give me a situation where our clinical focus will remain on delusional disorder, but we might shift our attention towards another disorder nonetheless. That is, the same content is in play, but maybe we're considering an alternative diagnosis. Give me the clinical scenario where this might take place. There's 3 things that I think instantly pop up, if not 4. And this gets at the definition of delusional disorder.
Would you say like hallucinations would kind of
How?
move it towards something in like the psychotic disorders rather than
Well, delusional disorder is a psychotic disorder. So what do you mean?
like schizophrenia or schizoid or
Not schizoid, but what?
schizoaffective?
Yeah, those are 2 of the 4 that I was thinking of. Delusional disorder should only be diagnosed when the delusion is not seen within the context of a larger mental disorder like schizoaffective or schizophrenia. Because if an individual has established schizophrenia and they come in with the exact same signs and symptoms of, let's say, Annie Wilkes, it's going to be hard for you to convince me that her delusions are not part of her pre-existing condition, but otherwise demanding of a secondary diagnosis. That would seem like pathologizing every aspect of this person's behavior. Right? So schizoaffective, schizophrenia are 2 of those examples, and what, of course, are the other 2 that always play a role in our clinical decision making?
Substance use?
Of course, and or
Medical.
yeah. Any evidence of either of those, what are often referred to as organic etiologies, playing a role here? I got a yes.
She does have a lot of medication.
She does have a lot of
So
medication.
anyway.
Because she's a nurse, right? So you don't know if she's taking.
Former nurse.
Wasn't, I said wasn't.
Sure, sure.
Yeah, probably like stealing pills from the hospital. Who knows?
Oh. So did anybody get a look at her medicine cabinet? Like Paul does.
I tried to.
You should pause it?
I was gonna bother him because I actually watched with my family. So I was like, wait, I have to let me pause it, and I was like, no, I can't see anything.
Yeah.
There's just the sound. There's no.
I tried to. I couldn't see
Only
it.
the orange pill.
Yeah, which isn't obviously isn't a real medication. But
Yeah,
It's from the
I remember
book.
Googling it. And it was
I
like,
did too, just in case. I was like, I don't
Human
know.
growth hormone.
I But it's
Yeah.
supposed to be like an opioid, like at least according to the book.
Right.
So that's like, I feel like
Right.
that's important to know.
And what's interesting is that opioids would not be considered or are not likely to induce psychosis.
Oh, really?
Right. So if you nerded out and you tried to pause this movie, as I did, and you come up with opioid, even if you've reviewed the book, doesn't really solve much for us in terms of this being a substance-induced or medication-induced psychotic disorder. See, does the same hold true for underlying medical condition? I'm going to take the pause as a yes, right? Nothing really jumps off the page. All right, so our working diagnosis appears to be within the psychotic spectrum. It looks like delusional disorder, although I guess we would have to see if she ever experienced any hallucinations, disorganized behavior, disorganized speech or thought process, or negative symptoms. That's where I think our questioning would go. Not necessarily evident in this movie per se, in this small snippet of time. But that's where I think we would guide our assessment. What else? Any other behaviors that are concerning to you?
She's super isolated.
Yeah. Mm-hmm. Yeah. Now, and I think that's central to a few things here, beyond her behavior, right? So if we're thinking she's super isolated, I mean, it looks like she just lives in an area of the nation that's super isolated. Not everybody who lives in an isolated farm has mental illness. There's just no way. There's no way we'd ever make that connection. But on the other hand, if she gravitated there because of her feelings and her thoughts, that's something to investigate. But I'm not sure.
Yeah, I think so. Just because her specific. I mean, it seems like it's just her specific house that's super isolated, but also they like there is a sheriff and they have like people that are around there, and it seems like a very like tight knit small town.
Very.
So that's why it's like
Yeah.
especially isolated.
And there is relevance here, and I think there's two things that we really have to consider that may not be patient dependent, but I think impacts where we're going with this regarding that isolation and regarding the very small town feel. If anybody here has read Stephen King, you know this is a typical Stephen King town, right? This is idyllic. This is Americana, and this, of course, under the surface, harbors some incredible sinister stuff. I mean, this is vintage Stephen King, and that's intended, right? So that's first and foremost. But there's I think, in a more directly, there's something more directly related to the plot of this movie.
Yeah, I think it's the fact that she like has committed these crimes and like is kind of hiding out somewhere. Like that's my impression of it.
Mm-hmm. Yep. So there's some premeditated nature to this, which again itself would count against schizophrenia and schizoaffective, where cognitive deficits.
Because it sounds very logical with
Yes.
like a criminal evasion
Yeah.
situation.
Okay. It certainly
Manipulative is what I wanted to say.
very manipulative.
Yeah.
Again, more supportive of delusional disorder, certainly counter to what we'd expect from the cognitive deficits that define both schizophrenia and schizoaffective, right? Previous to the DSM, whatever, dementia praecox. So it was the cognitive deficits that really were the focus of clinical attention for these debilitating psychotic illnesses. We're not seeing that in Annie. Matter of fact, it's the direct opposite. So much more consistent with delusional disorder than those other two quote-unquote larger disorders. There's something else here too.
Yeah, I didn't think, I hadn't even thought about delusional disorder when I was reviewing. I thought more of like, since it's so pervasive, chronic, long-term, I was thinking more of a personality disorder and something along the lines of like borderline for her, given like the black and white and like she flips back and forth. She has this splitting of like traits of ideas and like how she behaves. Like she can be nice, she can go out and get him the stuff he requests, but only if he's willing to bend to her ways that makes it right. And that it just seemed like that pattern of behavior. And instead of where I've seen borderline patients sort of anecdotally have like hurt themselves, but she hurts others.
Right. So what we're formulating here is that maybe the defense mechanism of passive aggression, where one would turn or inward turn anger to result in a suicidal gesture, which is defining of borderline, is replaced by an alternative defense mechanism. So acting out instead of acting in, aka passive aggression. Don't know why Annie didn't have, or why she doesn't employ passive aggression, who knows? But it certainly looks like she is more likely to act out than she is to act in. And again, that defense mechanism of acting in is called passive aggression, the inward turning of a nihilistic impulse, such as anger. And she's angry. Right? So maybe borderline, but with a little bit of a twist here with regard to the defense mechanism not necessarily being the one characteristic of borderline personality disorder. The other part of this, of course, is, and I would love to see the courtroom testimony, and even I would think a forensic exam that went into it, whether or not she was delusional at that time. Because in the absence of delusions, sure, I mean, I'd be concerned about a personality disorder. But there's still something else about this farmhouse and its isolation, especially in the opening scene. It's a hint. What happens in the opening scene?
She saves him from a car crash.
Mm-hmm. And how might that relate to the size of her property?
But
We're just gonna go see a new console if that's okay.
that it might extend onto her property because it was so close, like, and that she might have planned it. Basically, the car crash
Why would you say she planned it?
because of the
Ew.
location.
Because
of the location.
with the crowbar.
I mean, she's isolated.
Oh, that's
You
right.
saw the acreage of that property. What is the likelihood she would have just so happened to have been at the right place at the right time to save his life?
Those
With a crowbar.
Stephen King books are like known for the luck of it, but like if we were to throw that out of the equation.
And if that's the case, this is much more premeditated than we initially thought.
Yeah.
And again, it counts so much against schizophrenia or schizoaffective
I guess
disorder.
also like her saying that she, towards like the end of the movie, it would like speak towards premeditation because she knew the lodge that he stayed at, what he ordered, and
Everything, yeah.
like down to a T his routine when he would go there to write books.
Yeah.
And I think when she was medicating him, like that the first few days where he has huge gaps in memory and like is just not aware of anything, I think I don't think that the car crash, like that he sustained all the injuries from the car crash. Because like it was really bad. I mean, it flipped a few times, but like his entire body was basically like completely mangled. Like his legs were completely fractured. Like just everything. So I feel like she made it worse after she pulled him out of the car.
I think he was unconscious.
Yeah.
Did anybody get a look to see if he was restrained? Anything to look, now that you say that.
Restrained.
During the
Oh, seatbelt,
like-
yeah.
I feel
I'm
like it's
not
maybe
sure.
well, what year was this in? Like 80?
89, 90, something
Well,
like
he
that.
was still in the car. He had to be-
There were laws back then.
Yeah. I was
And he's
thinking
on a
more
mountain
I guess
road
I was
and-
thinking more like
Yeah.
60s.
Yeah, he was going to speed
Yeah,
limit.
I think he would have to be restrained because I think he would have been displaced from the car if he wasn't.
So if he was restrained, again, I have to look. I don't know if we ever get a glimpse of him, and I don't know. And I don't even know when she gets him out, whether or not that's evident either. But if he is restrained and he's got that extent of injury, the likelihood of her having done what you're proposing is greater than if he were unrestrained. That's just the point I wanted to make. But now I've got to go back and look at the movie again, which is fine. I have no problem doing that. Interesting. So, all right. And then, again, all this would be very consistent with what was proposed, and that is there might be a pre-existing personality disorder, and it looks like it's a cluster B personality disorder with aspects of not only perhaps borderline, but given this level of premeditation and harm to others, even the antisocial.
Antisocial. I was going
Right?
to ask about antisocial.
Yeah, well, she's...
But we would have to have more childhood background, right? These symptoms from 15.
Yeah, no, fortunately/unfortunately, it is provided to us, albeit in, is it Netflix, Castle Rock?
Hulu.
Hulu. Right? Sorry about that. Yeah. So I'm not so sure we get cruelty to animals or destruction of property consistent with conduct, but I'm not even. But then again, it picks Annie Wilkes up in her mid to late 20s,
Yeah.
not necessarily.
She's a nurse.
Right. Yeah. Right.
There's like a prequel series.
Yeah.
Oh,
Yeah.
there is?
Yeah.
Oh, I
Is
didn't
it
know
just
that.
for Misery or is there other Stephen King stuff?
It kind of combines her story with some other Stephen King
Yeah.
stuff.
Oh.
Yeah.
But would we be able to make that? We wouldn't be able to make
No,
that?
but that's a provisional, therefore guide our questioning.
Okay.
And I'm not so sure she'll be able to tell us, but and it looks like all her collaterals and social support
Are unavailable.
very again, very typical Stephen King. Right, but that's where we would go. And what we're talking about here is establishing conduct disorder prior to the age of 15, right? To allow us to rule in antisocial personality.
I don't think he has something wrong. There's like no
Yeah.
thing coming
No?
up from the other
Something
side.
back there. Can you? Why don't you just take a quick screenshot of that to me and send it? It's going to make somebody's PowerPoint.
Okay.
All right. Further thoughts?
And I did consider like bipolar at some point, or like leaning more towards the personality.
What did you see that made you think bipolar?
This emotional ability, lack of impulse control. Like, I guess the hard part is not seeing like whether she sleeps like a manic episode for like days on end.
Mm-hmm.
For sure, it's definitely like elevated mania.
Yeah.
It's very elevated and happy. Initially, at least.
Initially.
And maybe we're catching this. Maybe the entire episode and the months that he's with her is a mixed state.
And she has grandiosity. Like going through the past,
Mhm.
she has a lot of positives there, but I was like, for some reason, my gut said more borderline than BPD. But
Well,
they're both BPD.
the Castle Rock
Yeah.
series would definitely agree with you.
Okay.
She has established bipolar in the Castle Rock series.
Oh.
So, and the movie to some extent does support that. The other thing I wanted to bring up too, there's evidence of obsessive compulsive personality. Right? So,
Oh, yeah.
again, just to review the shelf exam, somebody tell me the difference between obsessive compulsive personality and obsessive compulsive disorder.
So with obsessive compulsive personality.
Well, let me cut you off real fast.
Sorry.
Your answer cannot include the words dystonic or syntonic.
No.
Now
Oh
go.
man. Okay. Well, that's what I was gonna say. I guess I'll just try to. Can I try to define it?
No. No. And the reason why is because there's actually a more obvious difference. That's why.
Is there
Yeah.
a one-word answer to this?
No.
Not that word.
Oh, I thought it was good. Okay.
Yeah, I thought it was going to be that word too.
Yeah.
Can we say it on the air here?
Impairment?
No, they're both impairing. Remember, what
one is
conditions
okay
in
with
the
it.
what?
Yeah, it's
So
like,
just that one's okay with it.
Yeah, I was going to say distressing.
One causes
Yeah.
distress.
They both cause clinically significant distress or impairment.
Oh, I didn't think that.
I thought that the
I
one
thought
that was
PD
ego. Yeah, I thought it was like in accordance.
That's why it should not be taught as such.
Oh.
Right. What are the only conditions in the entire DSM defined through not being clinically significant? It's only two. One is hypomania. Right? One is hypomania, and therefore cyclothymic disorder, which is defined through hypomania. Right? That's number one. Hypomania looks exactly like mania, with the exception that it is not clinically significant. Also, there's some time difference as well. Right? 1 week is the cutoff.
Is OCPD one of them? Okay, I didn't think so.
The other one is mild neurocognitive disorder, which differentiates from major neurocognitive disorder, not by symptoms. They're the exact same DSM criteria. In major neurocognitive disorder, aka dementia, clinical significance. In mild neurocognitive disorder, by definition, the cognitive deficits do not result in clinically significant distress or impairment. It's the other one. Right? So this only everything else in the DSM is defined through clinical significance. So getting back to my original question.
is it that it's more distressing to their family members than themselves?
Let's get off this distressing idea. All right, I've got two patients here. Okay, patient number one has obsessive compulsive personality. Look at her. Patient number two has OCD. Look at her. What are they demonstrating to you that is so obviously now easy for you to recommend or identify OCPD versus OCD? And by the way, don't look at them because they don't have anything, right? But we're having patients present to us. How will our OCPD patient present to us?
Well, right?
Well,
High achieving,
yes. High or super high achieving.
Or,
like super high achieving.
So much so that it's clinically significant. Give me a little bit more.
Organized?
Very organized. I mean, super organized or organized? Super organized. Anything else? Perfectionistic.
It's like everyone in this room.
Everyone take their white coats off. And let's see if the OCPD traits actually improve. That's exactly right. Type A personality equals OCPD. On the other hand, our other patient with obsessive compulsive disorder presents how?
Distress, non-functioning, low performance, I guess.
Due to what?
Inability to.
Anxiety? More specific.
Repetitive behaviors.
Yeah, being late,
Or?
can't do.
Compulsion.
Well, that's repetitive behaviors. Or the other part of the word.
Obsessions.
Obsessions. Right. Obsessive compulsive disorder is by far the easiest condition to recognize in a shelf exam because the individual will present with parts of the actual disorder. Obsessive thoughts and or compulsive behaviors. Could have both. One or the other that is clinically significant buys the diagnosis. That is not the case for obsessive compulsive personality. If you look at the definition of that personality disorder, the word obsession, the word compulsion is found nowhere in the definition. Instead, what is listed are every sign and symptom you think of when you think of the type A personality. Right? Overachieving, perfectionistic, requiring order and control. Right? That's type A personality, that's OCPD. Right? So when you say, and you use words like syntonic versus dystonic, it's not necessarily incorrect, but you're kind of missing the bigger point. Right? It's like saying the difference between the Empire State Building and an ant is that one is grayish and the other one is usually black. You're kind of right, but isn't there something else that jumps off the page? Okay, so please be able to pick that up on a shelf exam.
Do you think OCPD is misnamed?
Well, that's my next question. So, yeah, that's it. You just pimp your own peers. What about that?
It doesn't have obsessions nor.
It is a misnomer. Which the real question is, why in the world would anyone, except to confuse medical students, consider misnaming the condition the way they did? Any guesses?
I feel like that's how people thought OCD was. Like people thought.
I can't speak for the prior decades, but anybody? Etiology. Okay. So next question: what is the common etiology? It's called isolation of affect, and it's a maladaptive defense mechanism. Okay. So, what is isolation of affect? Other than being a maladaptive defense mechanism. Sports fans?
Is it like,
Sorry? Question?
is it when you like isolate how you feel separate from the situation
Yeah.
at large? Okay.
Yeah. So give me the example, sports fans. I got one nod. Nobody else is a sports fan?
Sports fan. What is the example?
What's your sports team?
I'll say the Sixers.
Philadelphia 76ers.
Yeah.
All right.
It's a sad fact, but.
So, as a Sixers sports fan, you come into work one day, and a very well-intended faculty member comes up to you and asks how that first overall pick of Simmons is working out for you, right? Exactly. See the reaction? Now, if I were a friend, right? If I were just a friend of yours, a cousin, family member, I'm not going to put you on the spot. How might he react to that question? By the way, it didn't turn out well, right? So for those of you who don't follow sport, again, friend of the family, cousin, asking the same question, what might his reaction be?
Be more dramatic or like truthful. Like he would just be like, "Oh, it was bad," you know.
Well, clearly he doesn't want to talk about it. So when you don't want to talk about something that is brought up and discussed or trying to be discussed by someone you are very familiar with, friends with, roommate, what might a true id-informed reaction be?
Be angry.
Yeah. Hey, yeah, go fly a kite. Maybe an explicative in there, right? I mean, okay. I got a yes. Thank you. The attending is usually someone that is a little buffered from those types of id-related responses for obvious reasons. So there's several things you can do. One of which is employ isolation of affect, where you answer me professionally because I got to fill out this Ryan P thing. But at the same time, you're not going to be emotionally invested in what you're discussing because it's too harmful, right? It's too threatening. So what happens subconsciously is that you separate the idea from the affect. The idea comes to conscious awareness so you can address me, but the affect is isolated in your subconscious, right? And if that is done, and if that is done rigidly and repetitively, you are going to be at risk for developing at least two mental disorders. One is called obsessive-compulsive disorder, and the other one is called obsessive-compulsive personality. And it serves risk as both, hence why we name those disorders similarly. Okay. Now, what results in the evolution of one versus the other? And the answer is, well, there's a secondary defense that is usually employed because the anxiety overwhelms the initial defense. That affect cannot stay isolated indefinitely. And it is going to overrun that defense mechanism, requiring you to come up with Plan B. If Plan B is undoing, you're going to actually present to clinical practice with repetitive gestures and behaviors that alleviate the anxiety caused by the ineffectiveness of that primary defense, isolation of affect. And you're going to be diagnosed with OCD. On the other hand, I mean, right now, are you getting a quick snapshot of what's going on internally or subconsciously? It's pretty chaotic, right? But yet, I might be able to turn this chaos into perfect order. I mean, buttoned up, tie perfect, hair perfect, and present with perfect order and control. That's called reaction formation, taking my internal state, which is utter chaos, and or I shouldn't say projecting it, that's going to confuse the issue. But certainly having it have a phenotypic expression as perfect order. The 180-degree opposite is achieved through a process called reaction formation. And if that is the defense that I employ as a secondary measure, then I'm going to present with obsessive-compulsive personality disorder. Right? So the initial defense is the same, hence the same name or similar sounding names. And whether or not you get diagnosed with the personality disorder versus the anxiety disorder has everything to do with the second or secondary defense that you employ.
I never thought about it that way before.
Yeah.
Can you give us another example of a reason why someone might employ isolation of affect?
Oh, the answer is the reason will be any reason why any person would employ any defense, and that is you use it and it works.
So it's like anything that would cause any kind of anxiety, basically.
Or that's like too much.
Well, any defense mechanism is employed for one reason, and that's to alleviate anxiety.
Okay.
When you have internal conflict, when your id wants you to do something, but your superego is preventing you from doing it or acting on that impulse, you're gonna be anxious. And the way anxiety is kept sub-threshold is through an ego defense mechanism. Which one you employ is probably random in the beginning. But if upon randomly, and I don't want to use the word choosing because it's not a conscious choice, but upon randomly coming up with a defense mechanism, it works. That positive reinforcement is almost going to guarantee that your use of that is going to be strengthened. Right? Positive reinforcement strengthens behavior in general and the use of a defense mechanism in particular. So it works, and you're going to use it again when the scenario pops up again. Defense mechanisms were originally thought to be mature, immature, narcissistic. That's rather outdated in terms of how to categorize. Now they are really adaptive versus maladaptive. And if you have a single defense that is your go-to 24/7, that rigidity is going to lend to it being maladaptive. What leads to a subthreshold or anti-anxiety state is when you can use various defenses flexibly, right? and you have some fluidity within which you use different defense mechanisms. That really allows and protects as a protective factor against future mental illness. So Annie Wilkes, because of that darn penguin, does demonstrate aspects of obsessive-compulsive personality. She did not miss that penguin pointing due south. Or, as it was, it should have been pointing due south, and it was not. That's OCPD. Are there any intrusive thoughts? Are there any compulsive actions or behaviors? I didn't see any. Right.
Well, she did. Yeah, this maybe wouldn't be like, super compulsive or anything. But she did say like that she thinks about using her gun, and that she's like, it seems like she's almost worried that she's going to use it. It's like a loss of control.
Yeah, I don't know if I would include any other characters you'd care to discuss here.
Talk about Paul Sheldon a little bit.
Okay, what's going on with Paul?
He's very superstitious. It's like been brought up a few times in the movie. Like he has specific rituals that he does. Like in the beginning of the movie, he when he finishes his book, he like has the single match laid out right next to the cigarette. It's like very precise the way that he does everything.
Any concerns there for anybody? I mean, if not clinically significant, the clinical term we usually or might hear related to this would be the overvalued idea, right? AKA superstition. However, if clinically significant, we usually change that out for other clinical terms. Obsessions, preoccupations. Thoughts? Pardon the pun. The one concern I would have, and I'd have to really investigate other signs and symptoms of whether there's any linkage here, is that individuals who are struggling, in this case with alcohol, tend to have very ritualistic behaviors, right? We see this with anorexia nervosa, ritualistic eating behaviors. So if somebody comes in and they're separating their peas and their carrots and they're only eating one at a time, is that abnormal? No, right? They're just separating their peas and their carrots. But if in the context of a fear of gaining weight despite being significantly underweight, we're going to view that behavior much differently. And that becomes a ritualistic eating behavior that is consistent with a larger disorder, in this case called anorexia nervosa. I don't know what's behind Paul Sheldon's rituals. But if there are other signs and symptoms that would suggest either alcohol use disorder or tobacco use disorder, his ritualistic behaviors, I think, would be taken in a different context. So that's something to consider and just store away for now. We know he's estranged from his daughter, right? Doesn't he dedicate his last book to his daughter, with whom he's not had contact for how many years? And as a psychiatrist, again, I think you'd want to ask why. And if it has anything to do with prior drinking behavior, boy, does his current rituals have a different outlook here. And it works vice versa too. I mean, if he is presenting with dysphoria, depression, because maybe it's his birthday, maybe it's his daughter's birthday, and no call. After I learn about his ritual of drinking, only drink when you write that book, I'm going to ask more about what may have caused his being separated from his daughter. Other observations about Paul Sheldon?
Probably his PTSD now.
He definitely has PTSD now. There's no doubt about that.
He says he thinks about it a lot, but also he
The illusion of the
Yeah, exactly.
I remember one.
Yeah, that's definitely. I don't think there's anything that, and that's the sequel. There's no sequel, by the way, but that will be the sequel. That's next for Hulu. Mm-hmm. Other thoughts? There's one thing about Paul, and again, I don't know how this at all owes to his relationship with his daughter, but he does seem to miss the cues early on. Now, I don't know if it's because he's under the influence of opioids. Certainly could be. But it also could be due to a pre-existing condition, and might it be also cluster B personality? Because if he understood the situation he was in earlier, he may have been able to get through it differently. It turns out okay for him, with the exception of the post-traumatic stress. Actually it turns out okay. I'm not saying that the connecting A to B was a walk in the park, far from it. But he may have went about it differently. Right? Instead of the different things he said, cursing, he missed it. And while I think our first concern or thought might be that it's due to his being under the influence, the prescribed drugs, there may be more there, especially when we learn that he's also distanced and estranged from his daughter. Might that be the same reason why?
I meant to mention this for Annie, but it's interesting that she dresses like very conservatively, and she acts in a very conservative way. Like, she does not like swearing. She's like super averse to any of that stuff. So I wonder if that has to do with, like, maybe it's obsessive, maybe it's because of a past trauma.
Yeah.
That she's so
Past trauma.
Yeah, I think so. Yeah, it's puritanical, and she's dressed as if she lives in the 1800s. And again, if you're in a situation where you realize I might be in trouble, maybe you pick up on that, and maybe you already have a working plan as to why you wrote misery out of that novel before she even gets a chance to read it. But Paul misses that. Final thoughts? All right, we'll stop it here. One second.